All right, you guys will actually read chapter 30, the entire chapter on your own, on assessment and diagnostics. We will start with chapter 31, which starts on page 633. All right, on page 633, we'll get started. Anemia is just essentially you have a low number of red blood cells, or the quantity or quality of the hemoglobin is low, as could be the hematocrit. The big deal is, red blood cells carry around oxygen, so when you have a lack of red blood cells, then you can actually have tissue hypoxia. Many of the signs and symptoms that patients get with anemia come from the fact that they have tissue hypoxia. Causes are numerous and diverse, but some of them can be blood loss. We have an impaired production of the erythrocytes, or we have increased destruction of the erythrocytes. This slide is listed on page 633, and it's just showing you why we have many different paths to anemia. And just remember, anemia can be mild, moderate, or severe. You do not need to know the specific hematocrit and hemoglobins associated with this, but understand if someone has a mild anemia, their signs and symptoms might only be present with exercise, as compared to someone who has a severe anemia. They could have signs and symptoms at rest. Another factor to consider is how fast did the anemia occur. When it happens gradually over time, patients compensate more easily and are actually less aware of their signs and symptoms. You can classify anemias based upon the characteristics of the red blood cell, the specific lab tests that diagnose the specific type of anemia, and the actual underlying cause. Is it because we have decreased erythropoietin, for instance? Is it genetic basis, impaired DNA, or is there something wrong with the actual bone marrow? We need to remember that as we age, certain issues come into play. So, for instance, older guys actually will have a decline in their hemoglobin, about a gram. This usually starts to occur after the age of 70. Some of this is because they have decreased production of testosterone. Ladies, it tends to be less of a decrease in their hemoglobin. About 1/3 of anemias in the older folks is because of a nutritional deficiency. Another third can actually be because, they have a higher incidence of renal issues. And 1/3 of them are just unexplained. We're not exactly sure why they're having issues or why they have. But just sometimes their signs and symptoms are actually more intense than someone who is younger. Most common type of anemia is iron deficiency anemia. This is found more often in very young populations that have a poor diet in women in the reproductive years. It is typically the result of we don't have enough in our diet, or for some reason we're not absorbing what we are taking in, such as the case with some GI surgeries. Blood loss is the most common, and then hemolysis, which means that there is increased destruction of the actual red blood cell itself. In most individuals, our dietary intake of iron is sufficient to meet the needs of the body. Sometimes that's not the case if you have like a chronic blood loss issue or you have increased destruction of the red blood cell. Okay, the goal is that we need to find out why someone's anemic and treat the specific cause. Not enough iron in their diet, increase the iron. Have a chronic blood loss, where's the blood loss at? Why aren't they not absorbing the iron? Some of the tests that can be done or found are back on page 628. So H&H, obviously you need to know those normal values. I will not hold you accountable for the normal values of everything else that's listed here. All right, so for instance, the MCV, if you go back to page 628 for the MCV, it will tell you that this actually measures the size of the red blood cell, and that's 628 26. The MCH measures the average weight. The MCHC measures the actual saturation of the cell with hemoglobin. The reticulocytes, those are your premature red blood cells, the premature red blood cells. So, how many do we have coming up that are actually going to mature into red blood cells? Your iron level is pretty straightforward. And you're looking at your iron level. And then you have your total iron binding capacity. And your total iron binding capacity takes into account all the proteins needed in your body to actually bind. And then platelets. And how many platelets do we have? Platelets, remember, help us to clot. Let's test the stool to see if there's blood in the stool. And then a lot of times we'll do an upper endoscopy. So this should say upper endoscopy. Look at the esophagus and the stomach and the beginning portion of the small bowel. Is there any ulcerations, any bleeding, gastritis? And then colonoscopy, which will look at the large intestine. Okay, so someone is diagnosed with iron deficiency anemia. We have to treat them based upon the underlying cause. Most of the time they're going to need supplemental iron. PO form is best. You can give IV iron, but it can be dangerous. There is a potential risk of an allergic reaction. It takes supplemental iron quite a length of time to actually increase the hemoglobin. What you need to know about iron is on page 638 under drug therapy. It tells you, for instance, that it's best absorbed in the duodenum and the jejunum, and therefore enteric-coated or sustained released are not a good form. It tells you what the daily dose of iron should be, and that it can be taken over 3 to 4 times during the day. It tells you it's best absorbed in an acidic environment, so take it with vitamin C. That helps increase the absorption. It reminds you that liquid iron can stain the teeth, so it should be taken through a straw. And it also reminds us that there's a lot of GI side effects. Most patients, if they'll stick with the iron, these GI side effects will subside, but some of the side effects can be anywhere from heartburn, constipation, and diarrhea, and change in the color of stool. The other thing is milk actually decreases the absorption, so milk actually decreases. So milk decreases the absorption, as does antacids and calcium. So you should not take your iron supplement with milk, antacids, or calcium. Okay, so probably the biggest thing on this slide, as many of the things we've already talked about, is diet therapy, and emphasize compliance, especially with the medications and patients, because like we said, they often take 2 to 3 months to work. Dietary teaching, what are some foods that are high in iron? So big ones are organ meats like liver, seeds and nuts. Sunflower seeds is a good choice. You can get it out of beef and lamb. Obviously dark leafy green vegetables such as spinach. Probably the best one though is dark chocolate. That has some iron in it too. So just make sure that your patient understands good dietary choices for iron.